Hello, hello, everyone. As you are coming into the room, please feel free to drop your name, your organization into the chat. All right, since we are getting started at the top of the hour, I will go ahead and kick us off. So, on behalf of the American Cancer Society and the National HPV Vaccination Roundtable, thank you so much for joining us today for Session 2, HPV Vaccination Quality Improvement Success Stories. So, again, as you are entering the room, please feel free to enter your name and organization into the chat. Next slide. Now, my name is Brianna Sally, and I'm a program manager of knowledge translation here with the American Cancer Society and the organizer of this learning community. So, for those who may be new to this space, this series is being held in partnership with the National HPV Vaccination Roundtable to convene healthcare practitioners and public health professionals to share promising practices and protect our adolescents against HPV and related cancers. We appreciate each of you for being here with us today. Next slide. And just to lay some expectations for housekeeping, please know that this meeting is being recorded. The slide deck and recording will be shared in a follow-up email after the meeting, and you are more than welcome to add any questions that you may have throughout the session in the Q&A box, as we will be pulling some questions from there during our live audience Q&A towards the end of the session. Now, the chat box has also been enabled, so if you would just like to comment, share your appreciation for any of our presenters today along the way, you are more than welcome to do so as well. And lastly, closed captioning is available. Next slide. Now, today's agenda is as follows. So, after the welcome, my fellow colleague, Megan Craig, will provide you with an intro to quality improvement with the Model for Improvement core concepts. Next, Dr. Carol Stippelman with the University of Utah Health will kick off our case study presentations with lessons from the field and academic medical center case study. Following Jaylon Ozcan from Santa Barbara Neighborhood Clinics will share lessons from the field from an FQHC case study. And we really look forward to engaging with you at the end in our live audience Q&A. So definitely, again, be sure to drop any questions that you may have into that Q&A box. And then at the end, we're just going to be closing out for the day with resources and a few more things that you may want to know about. Now, next slide. This session will cover the following learning objectives. We're going to discuss how to implement evidence-based strategies for on-time vaccination, effective provider-patient communication, approaches to vaccine hesitancy, quality improvement, and cervical cancer elimination. And then we will summarize how to address barriers to HPV vaccination, including vaccine hesitancy, access issues, and clinical workflows. Next slide. Now, as a reminder, this session is eligible for one live CME, CNE, or CE credit. Details on how to earn credit can be found in the CME, CNE document in the chat. And as a live participant, you must complete the SurveyMonkey evaluation shared at the very end of the session. So please be sure to stay on until the very last slide after the thank you just to get access to this evaluation, as it will not be shared in that follow-up email to those who are not in attendance. Next slide. Now, in preparation for the session, you may have received a few emails in response to a recent Zoom error that occurred and may have caused some discrepancies with our registration and calendar invitations. Now, we encourage all participants just to take a moment to confirm your calendar and manually add in any series dates that may be missing, just to ensure successes in joining all of our future sessions. We do truly apologize for this inconvenience and hope that this will just ensure smooth sailing for the remainder of our series. Next slide. But first, please participate in our pre-session poll. Just let us know. Let us know, how familiar are you with the model for improvement? We'll give you a few seconds to go ahead and fill that out. We want to try to get to at least 75%. So if you haven't already responded to that one poll question, feel free to put your response in that poll. And no worries if you're on a device where you can't see the poll, there's no worries at all. All right. We'll go ahead and close out this poll. Thank you so much for participating. Next slide. And we will jump into our first presentation. So first up, we have Ms. Megan Craig, who is an Associate Director of Community Partnerships here with the American Cancer Society. She's going to talk to you a ton about quality improvement, the model for improvement, and its core concepts. Take it away, Megan.
Thank you so much, Brianna, for that warm introduction. I am excited to talk with you all today about core concepts in the model for improvement. Next slide, please. So the model for improvement is a simple yet powerful framework for accelerating improvement. It helps teams focus in on clear goals, measure progress, and then test changes before fully implementing them. The model is two parts, and we will help you through the following steps. Forming a quality improvement team, setting clear and focused aim statements, establishing meaningful measures to track progress, selecting change that may lead to improvement, testing those changes through PDSA cycles, implementing successful changes, and then finally spreading and expanding those improvements into other areas. Part one in the model of improvement, the questions asked here are, what are we trying to accomplish? How will we know a change is an improvement? And then what changes can make that result in improvement? These questions help guide the team's direction and ensure that efforts are purposeful and measurable. The second part of the model is the Plan, Do, Study, Act cycle. This is also known as a PDSA. This is a method for testing changes on a small scale before wider implementation. It allows teams to learn from each test, make adjustments, and then redefine their approach. Next slide, please. So before jumping straight into a PDSA cycle, we first want to start by defining the purpose of the initiative, even if the goal isn't fully clear yet. Identify the system involved and what areas are going to be impacted, because improvement work is most effective with a strong team. To be most successful, we want to include a diverse team with insight into all parts of the process, leaders, managers, and frontline staff. An example of who to include on your team may include someone like a project lead, so someone who knows the day-to-day process. Health system leadership. This may be a project sponsor to help remove any barriers to work and help provide resources that may be needed. Clinical champions. This could be an advocate for the project and a subject matter expert. Quality improvement leads. So this is someone who is going to have experience with quality improvement and improvement science. And then technical expertise. So an IT or data specialist, people who know the ins and outs of your data and your IT systems. Clinical expertise. So someone representing from a specific clinic or representative of patient experience. So this is someone who is going to have that patient experience perspective. Next slide, please. The first part of this step starts with the model of improvement. There are three fundamental questions that help guide this work. And the good news is these questions can be answered in any order. However, most teams begin with the question, what are we trying to accomplish? This is going to help anchor the project and set a clear aim. Teams revisit these questions often, using what they've learned from each test cycle of change to refine their goals, measures, and strategies. So next, we're going to go through each of these questions listed to get a better understanding. Next slide, please. So you've asked the question, what are we trying to accomplish early on in the process when setting your aim statement? When asking this question, you want to be prepared to refocus your aim as you move through the process. When asking the question, what are we trying to accomplish? It will help define your aim statement by asking, what are we trying to improve? By when? So do you have a certain date in mind that you'd like to accomplish this goal? How much do we want to improve? By what percent are you potentially hoping to increase or decrease? Who is the target population? So you want to define specifically who that population will be. Where is this work happening? So, for example, is this going to be taking place with one clinic or is this going to be system-wide? And then why are we doing it? The reason behind what you're trying to accomplish. Next slide. So how will we know that a change is an improvement? You'll know this based on your established measures. You can look at your outcome and process measures. An outcome measure links back to the goal within that aim statement. So for example, this may have been the number or percent of 9 to 13-year-olds who have completed the HPV vaccine series. The process measure is what you may refer to ensure you are on track to improve the process. For example, if your outcome measure is for completion, you may want to track the number or percent of 9 to 13-year-olds who have initiated the HPV vaccine as a process measure. What these measures are will vary based on your aim statement and the best way to track it. Next slide. So here are a few effective measures to help you determine if a change is an improvement. You'll want to track your data over time. So seeking use for data, not necessarily perfect data. Use sample to save time and resources, especially if the data you are seeking is not easily available in your EHR. And then integrate the measurement into regular routine for data collection and keep in mind that your data can be quantitative or qualitative. Next slide. And lastly, what change can we make that will result in an improvement? This is when you'll want to refer back to your current state process map and revisit any gaps that you had identified in like a gap analysis or other parts of the process that may be getting in the way of a better performance. You'll also want to review best practices and what others might be doing to be successful. So this may be looking at evidence-based interventions or EBIs that others have done in the past or are currently doing to be successful. Next slide. So let's take a look at some examples and ideas that you can use for evidence-based interventions. Listed first here is system interventions, and things like that could include EHR enhancements, implementing provider assessments and feedback, and provider reminders and patient reminders. Some provider interventions listed here can include some things like having a clinical champion, provider assessment and feedback, standing orders, professional education, and reminders and recall. Patient interventions can include things like patient reminders, one-on-one education with the patient, small media, which could be things such as educational videos or printed materials, and then patient incentives could be things like gift cards or vouchers. And then access to care interventions. This can include things like incorporating patient navigation and community health workers into your process. Next slide. Thank you. And now on to part 2 of PDSA, which stands for Plan, Do, Study, Act. The idea is simple. Plan a change, try it out, observe what happens, and then adjust based on what you've learned. So keep in mind here that most changes won't be ready to implement after just one cycle. It usually takes several PDSA cycle testing, tweaking, and refining before a change is going to show enough evidence of improvement to be fully put into practice. So think of it as a series of small changes that's going to build towards meaningful and sustainable change. In the next few slides, we're going to go through each part of the cycle. Next slide. So this is a picture depicting going from a current state and implementing multiple PDSA cycles into a future state. And doing this step, you're going to use data to track and monitor your test of change. The change can be an EBI or improving existing parts of your process. This is going to allow you to properly modify the changes for future tests and eventually implementation that will help you get from that current state to your future state. Next slide. Implementation means making the change permanent by building the new processes. You'll know a change is ready to be fully implemented when it's been tested by starting small and expanding it over time. It works in different situations and settings, and then there's clear data showing that it's leading to desired results. So, after successfully implementing changes, teams can then expand them across organization or to others. Next slide, please. So here is a review again of that quality improvement framework. So first you want to form your team. You then want to use data to help determine where you are and where you'd like to be. Next, you'll decide on what your aim statement will be. From there, you'll be able to create an action plan on how to accomplish that aim statement. Then you'll want to map out your current processes and identify any gaps, and then begin testing your changes using PDSA cycles. And last but certainly not least is sustainability. You want to sustain those improvements. Next slide, please. So ACS offers many different quality improvement resources. These listed here are great places to start when you're starting to dive into QI work. There's EBI guides, QI templates, planning tools, and you'll even be able to find some specific related QI resources as well. I highly recommend using these resources as you're getting into the model for improvement. And with that, I am going to pass it back to Brianna. Thank you all so much for your time.
Thank you, Megan. That was a amazing, really quick run through of just quality improvement and all the major concepts that rely that kind of are housed within that. So thank you so much for that. I know for anyone who may not be super familiar with quality improvement, hopefully this was a really great introduction for you. Next, what we're going to be doing is transitioning into our next presenter, Dr. Stippleman. Are you able to see? Are you able to see me? See our
I'm able
slides?
to see you. I wasn't able to see the slides, so
Okay, I just wanted to make sure we weren't having any issues. So we're going to go ahead and introduce you. We have Dr. Carol Stippleman, who wears many hats here. She is a professor of pediatrics. She is a provider informatics, information technology, the associate division chief and director of quality improvement for ambulatory pediatrics, and the medical director of Intermountain Child Population Health Research at the University of Utah Health. She is going to be taking us through lessons learned from the field for an academic medical center case study. Take it away, Dr. Stippleman.
great. Can you see my
Yes.
slide? Oh, how wonderful. Yay. All right. Thank you, Brianna, for that very kind introduction. For the honor to tell you about our QI project to increase early HPV vaccination and to close the HPV vaccine gender gap at University of Utah Health. HPV is very common, and most of us will be infected by at least one of over 100 subtypes during our lives. Luckily, most of the subtypes are cleared without harm, but some oncogenic subtypes are associated with the 6 cancers shown on this slide. CDC data shows that over 42% of the average annual HPV-associated cancers in the US are in males. Oropharyngeal cancer is the most common HPV-associated cancer in males, and this type of cancer has increased over 225% in the last 30 years. Yet, despite these data, males are vaccinated against HPV less frequently than females in the US and globally. In the US, we began vaccinating girls against HPV in 2006 and boys in 2011. The NHANES data on the bottom part of the slide shows women under 26 years who were vaccinated prior to sexual debut had an 89% reduction in HPV infection compared to unvaccinated women. But those vaccinated after their sexual debut only had a 41% reduction. These results emphasize the importance of vaccinating the children early, well before sexual contact begins. And I think we're all aware of the efforts by the American Academy of Pediatrics and American Cancer Society to encourage vaccine initiation at 9 years because early initiation is associated with higher completion rates, a more robust and sustained immune response, and the children are more likely to be HPV naive. These were the most recent data available when we were planning this QI. Utah's HPV vaccine completion rates in 2020 were 45% for 13 to 17-year-olds, compared to the national rate of 59%. And there was also a significant gender gap. Out of 62 states and local areas, Utah ranked 59th. So we had some work to do. With support from the 2022 Mountain West HPV QI Learning Collaborative, we implemented a three-phase QI project to increase early HPV vaccine initiation frequency and parity between boys and girls aged 9 and 10 years at University of Utah Health. Our first hypothesis was not novel, that initiating vaccination at 9 years may decrease refusal by offering the vaccine before sexuality is typically discussed. This helps the conversation remain focused on cancer prevention rather than sexual debut. Our second hypothesis was, since there are 3 vaccines offered at the 11-year visit, the Tdap, meningitis, and HPV, offering HPV at age 9 when other vaccines are not likely to be due may increase acceptance. And our third hypothesis was that in our organization, medical assistants are the first to tell parents which vaccines are due at a visit. So our implementation science focused more on the medical assistants and parents and less on the education of providers. There were 31 outpatient primary care clinics that provided about 12,000 well-child visits annually for children aged 9 through 13 years. The clinics range from inner city to semi-rural, and the communities served range from underserved to highly resourced communities. Our phase 1 and 2 SMART goals were to increase early initiation by 50% during the year 2022 and to close the gender gap in the same time and cohort without suppressing girls' vaccinations while we focused on increasing boys' vaccinations. Our phase 3 goal was to produce patient portal and postal mail HPV outreach materials in the 10 most frequent system languages by the end of 2023. In the first 6 months of phase 1, we overhauled the way we ordered outpatient vaccines in Epic using a single order set curated by Central Pharmacy and a 2-click order from CareGaps, Epic's health maintenance tool. Also in phase 1, we set up an automated data query, presented to 4 different governing committees to receive approval for the project. Our resident champion presented at resident conference, and a system-wide email went out on the last day of phase 1 to explain the reasons for lowering the age of initiation in the electronic health record. Here's a screenshot of the new vaccine ordering system. It says 9 through 13 years on the slide, but before June 14th, 2022, it said 11 through 13 years. Now, if the child is due an HPV vaccine, the vaccine name appears under care gaps in the blue section on the sidebar on the left. And if you click on this green check mark beside the name of the vaccine order appears. And after clicking on the order, then the order, the associated diagnosis, and the administration charges are all entered with one single click. Here's the email that went out to primary care providers on June 14th, 2022, the day before the care gap's age was changed to 9 years. Phase 2 began on June 15th with lowering the care gap's initiation to 9 years. We gave educational presentations to providers and staff, and in some clinics, we had medical assistant competitions with prizes for the most 9 to 10-year vaccinations, with extra points given for vaccinating boys. The winners received coffee shop gift cards. These are the 3 medical assistant champions who provided system staff education with presentations and materials and led the medical assistant competitions. The champions divided the clinics amongst themselves to offer presentations or materials for the clinics to present themselves at the clinics. These clinics accepted presentations or materials. It was not required to participate. Phase 3 began in January of 2023, and this phase focused on centralized outreach to families. These portal messages you can see on the slide are sent to parents 1 month before the birthday of children aged 9 through 13 years, emphasizing the importance of HPV vaccine for boys and girls and translated into multiple languages. We also added American Cancer Society posters to the after visit summary. And next, and importantly, if the child was still not vaccinated for HPV 6 months after their birthday and through age 9 through 13 years, a letter was sent by portal or by postal mail if the family's portal was not active. On the left, you see the Spanish version, and on the right is the Swahili translation. We have care navigators who run our call center and provide information to families scheduling appointments. These are the smart texts that they still use to support their communication regarding HPV vaccines. We also have created a boy-specific HPV vaccine promotion poster that clinics hung or showed on their digital billboards. And that concludes phase 3 efforts. Let's look at some results. And if you'd like to read about this in detail, our manuscript describing the project was published in Clinical Pediatrics in January of last year. These are statistical process control or SPCP charts with the boys' results on the top over here and the girls below. And they're called P charts because they show the proportion of weekly 9 to 10-year visits in which the HPV vaccine was initiated. The red markers on the graph are called special cause variation in SPC, meaning the distribution of the data points is statistically unlikely compared to the mean, so there must be a special cause. So you can see in the week of June 14th, I put a red marker around this dot, when the system email went out, there was special cause variation in the girls with a marker that was more than 3 standard deviations above the mean, but it wasn't in the boys' data. In phase 1, you can see that the boys' early initiation frequency was at 15%, and the mean for the girls was at 19%. Then, starting June 15th, after the EHR care gaps change, the early initiation mean jumped by 231% for the boys and 167% for the girls. During phase 2, the girls' data hugged the mean, while the boys' data had wide variability around the mean. It looks like a roller coaster, showing that the process was not as controlled for the boys as for the girls, as we tried to change the culture around vaccinating boys against HPV. And this is another way of looking at quality improvement data. It's an interrupted time series. It's a little easier to understand. It shows the significance of the slope or the trend over time. And you can see in phase 1, the proportion of early initiation in the boys' visits was decreasing by 0.2% per week. After the care gaps change here, the slope became equal between boys and girls. For all of phase 2, the slope remained flat despite the educational efforts of the champions. In phase 3, the slope became significantly positive again, associated with our centralized outreach efforts. If you prefer non-time series statistics, this is before and after chi-squared analysis of each phase compared to the next. We did reach our SMART goal of closing the gender gap in phase 2, but it crept back in slightly at this point in time, with the boys at 53% and the girls at 57% with a p-value of 0.02. Now, this is not in the publication, but I went back and reanalyzed the interrupted time series with another 6 months of data through April of 2024 to see if the positive slope had been maintained after the end of the QI support. And the slope did continue to increase in a positive direction through April 2024. And the gender difference in the slope is not significant. And you can see at the end of this graph from 2 years ago that the mean early initiation frequency for the girls and boys combined was about 60%. Remember that 60% for the next slide. And for this presentation today, I refreshed the data to the end of February 2026. I was glad to see continued improvement in HPV vaccination in frequency and in parity. For 9 and 10-year-old children of both genders with a well visit, 74% had at least one vaccine dose, up from that 60% I just showed you on the slide from 2 years ago, and 17% before we started the project in 2022. And all of these non-significant p-values on the slide show that we have achieved and sustained gender parity. Our 13 to 17-year-old teens with well visits reached the Healthy People 2030 goal of 80% for the multi-dose older CDC schedule. And if you concur with the guidance that a single dose provides sustained immunogenicity, 90% of older teens with a well visit received at least one dose, with no difference between genders. There are limitations to the generalizability of the study since it involved a single academic center in a state with initially low HPV vaccination rates. Also, we can't take credit for all of the increases because our wonderful Utah State Health Department had their own educational initiatives, and they changed the USIS forecast to initiate at age 9 on May 7th of 2023, and that was right in the middle of our phase 3. For lessons learned, the immediate effect of changing the EHR care gaps alert to fire at 9 years was impressive. But I was also surprised that there was no further increase in the following 9 months, despite our educational efforts. In contrast, our personalized message to the parents in phase 3 were associated with steady improvement over time that continued 2.5 years after the end of the QI project. So in conclusion, we increased early initiation of HPV vaccination, and we achieved gender parity using EHR decision support, education, and messaging to families and staff. We are so very grateful to the American Cancer Society's support of this QI project and for helping us save some lives by increasing HPV vaccination. Thank you very much for your kind attention, and I look forward to your comments in the discussion period.
Thank you so much, Dr. Sibbleman. That was a very in-depth, amazing presentation with tons of data. And even our audience was asking, are these slides going to be shared? And yes, they are. Fret not, they are going to be shared in our follow-up email. So do just be on the lookout for that following our session. Thank you. All right, so next we're going to transition into our final case study. Thank you so much, Hannah. All right, our next presenter is going to be Jaylon Ozcan, the Chief Quality Officer of the Santa Barbara Neighborhood Clinics. Again, she is going to be presenting on lessons from the field from an FQHC case study. Take it away.
Okay, thank you so much. I'm really grateful for everyone who joins this call, and I hope that this will be helpful for people. I also was really happy. I saw a couple county health folks in here. I saw some nurses. I love meeting fellow nurses. So I think I'm going to give a little bit of a different perspective here because I do work at an FQHC. So you can see on the screen, we're about a medium-sized FQHC, about 20,000 patients. What is not on the screen that I think is important is most of our patients, or a vast majority of our patients, are Hispanic or Latinx. It does say on here that predominantly low income, uninsured, and underinsured, but also a very large proportion of our patients are Medicaid recipients. And the reason I mention that is because HPV vaccination rates are lower in our patient population, like overall, like lower in folks who are Hispanic or Latinx, lower in Medicaid patients than in kiddos who are insured, and lowest in kiddos that are completely uninsured. So we're serving a really vulnerable population. And then also cervical cancer incidence is higher in Hispanic and Latinx women as well. And this is a population that doesn't always have high health literacy. And again, I mention this because vaccination rates are associated with high health literacy, with education, and with income. So I feel excited that this is the population I serve. I think it's a privilege to serve them. And I hope that this will be helpful, not just to the FQHC folks in the room, but to other folks as well. Next slide. Oh yeah, you're perfect. Next slide. Yeah, thank you. Okay, great. So how did we get here? So we had the opportunity in 2024 to work with American Cancer Society. That was our first QI project with American Cancer Society, and I'm so thrilled. We've actually been working with them since, and it's been fabulous. At the start of our project in 2024, HPV vaccination rates were about 40% overall for both genders. And of course, why do we care about this? Dr. Stippleman talked about this. Vaccination prevents 6 different types of cancer. This is, and again, I mentioned our patient population in particular is at higher risk and is not getting the care that they necessarily need, right? And then something interesting as well, our pediatric team was not super engaged in QI initiatives. And this was more of an issue with leadership than with the team themselves. But this was a great opportunity to involve the PEDS team for the first time when everything was really focused on like adult medical care. So I was really excited about that opportunity and just in general to improve our culture of continuous quality improvement, which I think we have done over the last year and a half. But so our goals when we started with ACS were improve and sustain HPV vaccination rates. We want to get more shots in kiddos, right? We also were really hoping with this to improve our vaccination workflows in general. When you start to do a deep dive into something like this, it gives you the opportunity to do a process map and see where are there discrepancies, where can we improve? And again, a big goal was to really engage that pediatric team in QI/QA. Next slide. So I'm going to break the rest of the presentation down into like these 4 areas. So provider assessment and feedback is really where I think everything should start. Provider and staff education. A big value of mine is that everyone owns quality. So departmental collaboration. And then at the very end, I'm going to talk about monitoring. I highlighted this in teal because I think that this is something that folks are not always comfortable with. And so Dr. Stippleman really also talked about this. But I know that data can feel like black magic or that's something that's done behind a curtain. But I think it is important to not only monitor, but to share out successes and barriers. Next slide. So I started with provider assessment and feedback. So we started with American Cancer Society. When we really hadn't been looking closely at this, to be totally honest. So I started with looking at the data. So I was like, let me pull like performance by provider, right? So I think that, and that's actually something I still continue to do with any measure I'm looking at, whether it's cervical cancer screening, colorectal cancer screening, HPV immunization. And I start with talking to the highest performing teams. And when I started that conversation, it was interesting because I started with the providers at first. And of course, like they are leading a huge part of this. But then I really have been focusing on talking to the frontline staff. In our organization, we have our phlebotomists actually are doing the vaccination. But I talk to the MAs and the phlebotomists, like where are your barriers? Where are things going well for you? And when you're talking to those teams that are struggling more, you also want to do this in a kind way. And they may not even realize that their panel of patients is not getting vaccinated. When I started to talk to the providers, the lower performing teams consistently said to me, I always offer HPV vaccination. I'm really surprised by these numbers. And they had never been shared with them before. Next slide. So through that provider assessment and feedback, I learned some interesting things. I learned that not everybody was starting at age 9, even though this was an established science at this point, an established recommendation, right? And so when we talked about this, it was a couple things. There were a couple providers who were not completely up to date or were actually not super comfortable even with this conversation. And then when I talked to the staff, the medical assistants, because they, as Dr. Stippleman also said, they are the first folks who are engaging with that patient. And I asked them, why are you guys starting at age 11 if we know that it's age 9? And we learned that our tool that we use, our tool from the California Immunization Registry, I don't know if other states have a similar registry, but we print the record from there so we can reconcile. It was showing to start at age 11. Starting at age 9 was optional. This was a big piece for the staff because care is the thing we trust. It is our huge tool. And so, of course, we can continue to trust it, but getting that mind change to start at age 9 was a big deal. In talking to the staff, those old myths really were pervasive of girls are the only patients who need this, and this is for people who are sexually active. This can start as teens. And so we really have been focusing our education to the staff on this is cancer prevention. This is cancer prevention. This is cancer prevention. And that has been the most impactful. I do also talk to the staff about if we can vaccinate early, it's fewer vaccines. And again, that sustained immune response. And that's also been really helpful. But this cancer prevention is what has gotten people the most comfortable with this vaccine in particular. We also talked about using presumptive language. And again, this was from that provider staff and feedback, but this is now part of our education because the medical assistants and phlebotomists reported just not feeling comfortable having these conversations with parents. And so using that presumptive language, okay, Jaylon, part of today's visit will be the HPV vaccination. This is shown to be a helpful intervention, and we've really been focusing on that. And even in our role play, even in our staff meetings, using this presumptive language around each other has made people more comfortable with these conversations. And then, of course, decision aids, my favorite. These are below our actual SNPs from Azara. That's what we use. I know, of course, Epic has their care gap functionality. You might be using Eye to Eye or Relevant or something else, but having these visual decision aids has been critical for our care teams so that they can capture those kiddos who are due, not just at a well child's visit, but at any type of acute visit. Azara is able to tell us if they are due for their very first vaccine. You can see that alert there that says HPV immunization due 1. It tells us if they are into the series, that last alert HPV immunization due 2, and you can see most recent 4/23/25, dose 1. We also put owners on all of our alerts. So this one is lab and provider. This is helpful for expectations, but this is actually also just another visual cue. When the staff is doing their prep or their daily huddles, it's really helpful for them to see, okay, what is my focus for today? Next slide. Another thing that's been really important and honestly really fun for us is departmental collaboration. So I mentioned earlier, everyone owns quality. And I don't know if this is an issue at your sites. I think that this is pretty pervasive everywhere, but our organization really used to function in silos where dental and behavioral health and medical were all separate. And recently we have a collaboration with dental that we never had before. And so my department, our quality department, is for everyone. And so I've been working closely with our dental director on this. And you're like, okay, Jaylon, why do we need to play together in the sandbox, right? This matters for our patients. HPV is a leading cause of oral pharyngeal cancers. This is huge. And at least for our practice, our dental practice sees kiddos often, extremely frequently. And they may sometimes see them more frequently than medical or than well childs. We also have dental services at schools. And so we have all these rich opportunities to do this education. And the more that parents and patients are hearing this from different trusted providers, the more impactful it's going to be. And again, I said this has been fun. It really helps us feel integrated. It really helps us feel like a team. It really helps us feel like all of us are advancing the mission together. So we started with staff and provider education using a lot of American Cancer Society resources. We provided flyers on HPV vaccination that are beautiful, again, from American Cancer Society, that they can post in the rooms. Again, those visuals can help, especially when you have folks waiting. And then the thing that I'm most proud of, one of my quality staff actually scrubs charts every week for the following week to identify kiddos who are due for well childs and due for vaccination. And the reason we have a quality person doing it rather than one of the dental assistants in dental is she's able to cross-check care, again, that immunization registry. She cross-checks their Medicaid eligibility or if they have insurance. She cross-checks if they're already coming in for an appointment. But this is beautiful because she does that scrubbing. She sends it to the dental managers, and then it's that opportunity for the dental staff to bring this up and sometimes get those kiddos scheduled. So that's been something special that we had never done before. Next slide. So then finally is to my monitoring. So the next several slides are going to be about all about monitoring and all about data. I think that no decisions should be made without data. This is really informing everything. And this is how we know if we're getting better and if our interventions are working. When we talk about monitoring, I really suggest looking at multiple things. So I'm going to talk about alert closure, performance by care team and site, initiation and completion, and overall performance. I think that we can get really focused just on overall performance, but there's pieces in there that I think are important. This is an actual alert closure report for us. I thought it was interesting to include other adolescent vaccines. So I have meningitis, flu, Tdap on here to show how if our alert closure is following those other immunizations, because in the past we would have better alert closure or more vaccinations of Tdap, for example, than we did for HPV. As you can see, though, those lines are following each other more closely, which I feel excited about. And this helps me understand on a weekly basis how many gaps were closed or how many of these kiddos were addressed at that visit. So I think alert closure is something super helpful to look at. Next slide. So performance by care team and by site. This graph up top is a little bit tricky. We have a provider who recently joined us, that orange line. I still wanted to go ahead and include them, but that's why there's a little bit more fluctuation. They're still building their panel of patients. And of course, you can see they joined us in November. But everyone has been on the uptick, but you can see there are still disparities in provider performance. And so this, again, really helps us target those teams that maybe are struggling a little bit more and to really talk to that frontline staff that's been super successful. And then I also look at performance by site. We do have some providers that go to different clinics. And so this helps us understand too, how the staff also are affecting this or how that patient population at that clinic might differ. And this has again been super helpful for us. The way I really have been using this recently, because training is ongoing, my friends, I have been talking to the care team and the lab assistants at the highest performing clinic and just asking the staff themselves, what's working well for you? Why have you been so successful? I take that, I make those recommendations to the rest of the team, and I make sure to give that staff member her shout out as well for just doing an amazing job and being open to this quality improvement. And that really, that's one of the things that engages staff most is just talking to them. Next slide. So then, we looked at alert closure. When kiddos are coming in, are they getting their vaccine? And then performance by care team and by site overall. And those performance, that is for HPV completion. So then on this slide, I have series initiation versus series completion. I am proud of these numbers because we used to have a really huge gap in initiation and completion, about 20%. So I was like, okay, this is great that kiddos are getting their first vaccine. Why are we not getting kiddos back? That's been a really big focus the last 4 to 6 months for us. And so we've really improved that series completion. A big thing, again, I talked to the staff. I just asked them, your completion at your site is highest. What are you doing differently? And one of the big things is just getting those kiddos scheduled for their next appointment. But I feel really excited about that. And I love sharing this out to the staff and showing them, look what you've done. Look what your work has done. Look at you. Look who you're affecting here. Next slide. And then finally, we look at overall performance. So this is like our hot off the presses performance. So you can see in 2022, we were at 36% series completion by age 13. We've really been focusing on starting at 9, but then that 9 to 13-year-old age. And of course, I want to call out all of us have been catching up since COVID, right? This was not an easy thing to bring back. But as you can see, we were already starting to improve 3 years post 2020. And then at the end of this is end 2024, we got up to 48, almost 49%. And now, as of like right now in 2026, we are at 62.79% series completion for this age group. And we are thrilled about this. Again, I really share this with the staff frequently. They are the ones doing the work. Like, yeah, I'm here. I'm doing oversight of this program, but they're the ones facing the kiddos, facing the parents, giving this education frontline. So this has been something that I've been really thrilled to share with everyone. Next slide. And then for my final wrap up, lessons learned, I just can't emphasize enough provider assessment and feedback. Talk to your frontline providers and staff, not just the providers, but the staff too. They're the workflow experts. And solicit feedback, solicit the challenges too, and listen deeply when they share those challenges. It can be hard or frustrating when you're not seeing change right away. But if you are listening deeply, they're going to be more willing to share with you. I will tell you, this is of our whole QI program, this is the thing I am most proud of at our organization, that we have built a QI team that the staff is open to sharing with. I actually get pediatric MAs reaching out to me, or all staff, but most recently we've been working on HPV vaccination and fluoride varnish. But I get staff reaching out to me directly with questions, with ideas, with suggestions. When I reach out to them to solicit feedback, just simply tell me about your workflow with HPV vaccination. They share because they feel safe doing so. Provider and staff education never ends. Training is ongoing. Also, we have turnover. You want to make sure that this is part of onboarding and that this is continuous. Every time that I share the numbers, I provide a piece of education too. And I try to link this back. We're also working on HPV screening. We have a new grant for that, and we're trying to expand HPV screening across our clinics. I am linking our HPV vaccination, our HPV screening, and discussions about cervical cancer all together. So we're bringing in adult and pediatric providers, family practice providers, and care teams, and letting everyone know how their work impacts the patients and impacts outcomes. Again, that departmental collaboration, no one's in this alone. All of us have opportunities. All of us have expertise. And I think it's important that every service line, every staff member, every provider knows that everyone owns quality. This is not just something that's done in admin. This is not in an ivory tower. All of us are in this together. And again, our patient population is one of the most vulnerable. And so this is just a beautiful opportunity to make a difference. And then monitoring. Even though we started this project in 2024, we still look at these numbers regularly. We still share them out to the staff regularly. And actually, even as of last week, last Friday, I was part of the lab assistance meeting, and we talked all about HPV vaccination and ways to get that series completion. Again, investigating the barriers and celebrating the wins. It is so meaningful. It is so meaningful to your care teams to celebrate where they're doing well. That has been, I think, what's sustained us. Again, it's what's kept our people engaged. And with how hard everyone is working, I think that they deserve to feel really proud of their work. Next slide is just my contact info. Feel free to reach out to me. I'm so thrilled to talk anytime. If you want to talk Azara, next gen, HPV vaccination, PDSAs, you're welcome to email me.
All right. Thank you so much, Jaylon. And it looks like you've gotten some love for just being super informative, breaking down silos, and so much more in the chat. So definitely be sure to check that out if you haven't seen it already. Next, we're going to quickly transition into our Q&A. I know we are a little bit limited on time, so we're going to go through some of the questions that kind of came through in our Q&A box. Again, we have Megan Craig, we have Dr. Carol Stippleman, and Jaylon Ozcan with us. So the first question was for Dr. Stippleman. Did your team create a custom health maintenance alert, or did Epic provide for support for the change?
It's a great question, and it was a combination. So, when we did the project, being able to order vaccines from Care Gaps was new, but it's definitely Epic Foundation now and available to everybody. We had to customize the change from changing it from 11 years down to 9 years because that's not Epic out of the box at this point. They're waiting for, CDC confirmation. So, but that's just a few lines of code. But the custom part that we added that I feel was the most effective, first of all, the fact that pharmacy curates a single order set in our organization. Before it was the Wild West and every clinic could make their own vaccination order set. And for instance, Menactra would stay on forever after you've switched to Menveo, and providers would have to sift through. So there's one order set. As soon as the vaccine is discontinued, it's taken off. So there's no thinking involved. But the part that we really love is the associated diagnosis and the immunization charges, everything get dropped at once. You order the vaccine and all of that gets dropped at the same time. So it's really just one click ordering. So we built that part, but you can get the health maintenance alert from 11 years from Epic out of the box.
Thank you so much. Next, I am coming to you, Jaylon. A question came in. What about clients eligible for HPV vaccine, but they do not have insurance?
Oh, my friend, that's a hard one. In California, we have vaccines for adults and vaccines for children, and so we are able to give those vaccines even to uninsured patients with no cost to us. What I would suggest if you don't have that, I would look for similar grants or work with your local Medicaid plan because if you can get other vaccines covered, that cost offset may help you get these folks covered.
All right. Thank
Yeah.
you. I'm so sorry, all. We are running out of time for our Q&A. We're going to have to transition to our closing, but I do appreciate everyone for engaging in this amazing quality improvement conversation, and for just engaging with our panelists today. Thank you so much. Next, we'll go ahead and transition into the closing. But for my presenters, do be sure to check out the Q&A box. I believe there is one more question that we didn't get to, and maybe just typing in a response that
Mhm.
way. Well, we'll go ahead and jump right into our post-session poll. So how familiar are you with the model for improvement following this session? I know this was a lot of great content today, so I'd just love to hear where you currently stand with that. And then in the next 6 months, how likely are you to implement the different steps of the ACS quality improvement process in your HPV vaccination efforts? So this will be, again, things like forming a team, using data, setting an aim statement, creating an action plan, mapping processes, identifying gaps, testing changes, sustaining those improvements, and all the above. And if you are interested in presenting a case study like our amazing presenters today in the future, please let us know. We'd love to know what topic you would be interested in, or if you have an idea that you'd like to present. We are always looking for new talent and would love to be able to host you on one of our sessions. We'll give you a few minutes to go ahead and respond to that poll. And as you do, we're going to continue on through a few other slides. So, as we wrap up, there are just a few different resources that I definitely want to call to your attention based on today's content. Now, the ACS National HPV Vaccination Roundtable's Best Practice Task Group did develop a series of brief, easy to read summaries highlighting what's known, what's new, what's next, and a few different other topics related to HPV. Now, most of these were shared in session one, but just to piggyback off of that, there has been a new summary released on the safety and effectiveness facts of the HPV vaccine. Again, this slide deck will be shared, and you're more than welcome to follow those links to check those out. Now, I know we have a few more slides still, and we may be going over time, so just want to give everyone a heads up, just a few minutes over, just to get through the last few slides for you all. So additionally, we have compiled a few resources just to help you with implementing some of those EBIs that we discussed earlier. These material resources can be used for patient education with great graphics and contents for those visiting your clinics. Next slide. Now, we also have our HPV vaccination social media toolkit to help you promote this vaccine year round, and all of those resources are available in English and Spanish. Next slide. Immunize.org has also updated their standing orders template, and this may assist you in your HPV vaccination efforts as well. So definitely feel free to check that out. That's something that you're interested in. Next slide. Now, ACS and the HPV Roundtable have also produced an on-demand provider education series in a range of topics just to equip our providers with the latest information on HPV guidelines, the science, implementation strategies, just to increase HPV vaccination rates. So if you or someone you know is seeking provider education resources, definitely be sure to check out that free series. And lastly, we briefly touched on presumptive messaging. The announcement approach is a great way to more effectively recommend the HPV vaccine. So this is a great resource and guide in introducing the HPV vaccination to parents, counseling them, and responding to those hesitations that may come up in a brief and efficient way that really just normalizes vaccination as a standard of care. Now, next slide. Now, for those who may not know, ACS's implementation science team has successfully launched the ACS Accelerating Research to Care, or ARC network, which is a three-tiered approach that ensures optimal resource allocation and meaningful impact. Knowledge translation is the first tier within this, which Promising Practices falls under, and it has developed a web page to house everything related to our programming. So this is now going to be our one-stop shop for all things Promising Practices. Please feel free to check out our new webpage and review all program materials. I would just like to call out that that second bullet under Promising Practices does list the series recording and slide deck, which will take you to the learning materials library that you may have become familiar with since the start of the series. So following today's airing, all session recordings, slide decks, and resources can be found on the Program Learning Materials Library, and a follow-up email will be sent letting you know that all content has been updated like our recording. And if you have any questions accessing that, always feel free to reach out to implementationscience@cancer.org. Next slide. Now, I would love to invite you, your colleagues, your network to register for our next sessions as we will dive deeper into topics surrounding HPV vaccination and a surprise session on cervical cancer elimination this December as the program works to begin incorporating more and more topics from across the continuum. Now, following the Zoom error that we mentioned earlier, some participants may have received an incorrect invitation to a Promising Practices session on May 21st. To confirm, our next session will be taking place on June 18th, none in May, on June 18th from 2 to 3 Eastern, discussing HPV vaccination partnerships and gearing up for that back to school season. And we really hope to see you there. Next slide. Now, if I'd just like to leave you with a few different action items for you all. Definitely be sure to check out those QI resources and the QI process if you aren't as familiar that we shared a little bit earlier to help you with your HPV vaccination efforts. And if you are a health system that is maybe looking to identify some different EBIs to begin implementing and advancing your local rates, definitely be sure to check that out as well. Now, of course, don't forget to register to join us for session 3, Partnering for HPV Vaccination Progress. Again, this is going to be taking place on June 18th. Next slide. And lastly, if you are a rural health partner, this is just another educational opportunity that you may want to take part in. The Rural Learning Community is going to be hosting session 3 on May 13th, and monthly sessions do take place on Wednesdays from 2 to 3 Eastern, and registration is always rolling, so feel free to join in at any time. Next slide. And thank you so much for joining us for session 2 of the 2026 Promising Practices series. We'll go ahead and stop the recording here. And for those of you who have been waiting, we will go